Hi there, my name's Scott Peirce. I'm one of the authors of a physiotherapy framework to manage long COVID, a clinical approach. I wrote this article with Mitchell Taylor, a physiotherapist from Australia, Talia, Pollok, a physiotherapist from the United States, Samantha Holtzhausen, physiotherapist from South Africa, Brooke Peirce, a physiotherapist from New Zealand, and Jessica DeMars, a physiotherapist from Canada. This paper is really a clinical informed framework for managing long COVID from a physiotherapy background. All of us are clinicians. No one is in full-time research, and we teach a variety of long COVID and other courses. So the paper outlines the pathophysiology of long COVID, which is more research has illuminated the backgrounds to that. But some of the more important ones that physiotherapists need to be aware of, we highlight, including muscle and mitochondrial dysfunction, which can significantly drive post-exertional malaise or post-exertional symptom exacerbations. We also describe diaphragm dysfunction, post-COVID interstitial lung disease, breathing pattern disorders, and dysautonomia and vagal nerve dysfunction. And physiotherapists should be aware of all of these different pathophysiological mechanisms when treating patients with long COVID. We then go on in the article to describe a framework where we are asking physiotherapists to be aware of screening for red flags. And we urge that patients coming through with long COVID be screened for cardiac muscle damage or issues with exertional desaturation. And then also, if the patient presents with a condition that has been exacerbated by or has been caused by long COVID, and there are published treatment pathways such as asthma, which may develop after long COVID or after COVID-19 infection, or maybe exertional desaturation, but manageable. There are some guidelines published for this, so we advise people to follow these published guidelines. And then finally, we also urge physiotherapists to screen for post-exertional malaise, post-exertional symptom exacerbation, and be aware of the pathophysiological mechanisms and signs and symptoms. So PEM and PESE, we're really looking out for symptoms that appear, that sometimes can appear fatigue-wise, that can be delayed, and it can be extensive and can increase rather out of proportion to what a patient is doing. So severe fatigue, say, after walking around the block. The duration of fatigue is extended in PEM and PESE, and patients and physiotherapists need to be aware of managing that, and activity intolerance is really important to understand. From that group, we think it's really important as well that people are aware that not all physiotherapy treatments that are being proposed will suit people with PEM or PESE, particularly exercise therapy. There is a significant risk of harm. And so we go on to propose several different risk profiles for different phenotypes and conditions. So we describe sort of 5 main physiotherapy amenable phenotypes in long COVID. PEM and PSE is 1, post-COVID ILD is the 2nd, dysautonomia the 3rd, breathing pattern disorders 4th, and chronic cough is the 5th. There are improving and more research on each of these different phenotypes, and they all have their different treatment pathways, but they aren't usually not mutually exclusive. So someone with post-exertional malaise may show up in clinic with chronic cough or with a breathing pattern disorder or with lung disease. And so it's important that people keep screening for each of these conditions and monitor and change their exercise-based therapies or stop treatment altogether, particularly if it starts to worsen fatigue. We hope that the readers will get a sense that, there are some specific and clear ways we can identify these phenotypes. There's some specific ways we can treat them, but it's not all just go, go, go and start treating these patients. Caution must be urged. For instance, one of my favorite treatments is inspiratory muscle training, but caution must be urged applying this in some of these phenotypes because it may significantly worsen the patient's outcome. We hope people read the journal article and enjoy it and enjoy the rest of the journal articles presented by other authors. And if anyone's got any questions, they can feel free to get in touch. Thanks very much for listening.